A 65-year-old male with a long history of chronic obstructive pulmonary disease, COPD, is brought to the emergency room complaining of shortness of breath, fever, yellow sputum, and lower extremity edema. Physical examination reveals cyanosis, finger clubbing, and bilateral lung wheezes. The question is, which of the following findings is most likely in this patient? The choices are A, normal arterial blood oxygen content, B, normal mixed venous blood oxygen content, C, increased pH of the arterial blood, D, decreased pulmonary arterial resistance, E, decreased cerebral vascular resistance. If you know the answer, click the like button. If you're an average person, keep watching. The correct choice is E, which is decreased cerebral vascular resistance. The brain has a very high oxygen requirement, about 20% of all oxygen consumed by the body, and thus receives approximately 15% of the cardiac output. The patient in this vignette has long history of COPD and is likely to have hypoxia, low partial pressure of oxygen, and hypercapnia, a high partial pressure of carbon dioxide. Hypercapnia produces cerebral vasodilation via a decrease in cerebral vascular resistance. Brain tissue has little room for expansion because it is encased in the cranium. Thus, even small increases in cerebral blood flow can raise intracranial pressure and cause compression of the brain. In order to maintain a stable intracranial pressure and provide sufficient delivery of substrate and removal of waste, cerebral blood flow must remain relatively constant. The main factors influencing cerebral circulation are the systemic blood pressure and the arterial blood gas levels. When it is between 60 and 140 millimeter mercury, the systemic blood pressure has little effect on the cerebral blood flow because autoregulation via cerebral blood vessel dilatation and contraction keeps blood flow constant. Blood pressures above 150 millimeter mercury will cause increased cerebral flow and increased intracranial pressure, and decreases below 50 millimeter mercury will cause hypoperfusion and potentially cerebral ischemia. The arterial blood gases have a more powerful effect on the cerebral blood flow, with the partial pressure of carbon dioxide as the most important regulator. The cerebral blood flow increases and decreases in a direct and linear relationship with changes in the partial pressure of carbon dioxide. The partial pressure of oxygen has a less profound effect, though partial pressure of oxygen decreases below 50 millimeter mercury, cause a rapid rise in cerebral perfusion. Supplementary oxygen must be used judiciously in patients with COPD because hypoxia reduces their respiratory function, whereas in normal individuals, the partial pressure of carbon dioxide mediates the respiratory drive. In patients with long-standing COPD, oxygen supplementation can lead to respiratory suppression and coma. Let me explain why the other choices are incorrect. Choices A and B cannot be the answer because patients with COPD have low arterial and venous oxygen content. Choice C cannot be the answer because COPD is characterized by increased partial pressure of carbon dioxide hypercapnia, which causes respiratory acidosis with a low pH and a high partial pressure of carbon dioxide on arterial blood gas analysis. Choice D cannot be the answer because chronic hypoxia in COPD causes pulmonary vasoconstriction. Pulmonary hypertension and cor pulmonale are frequent complications of COPD. If you still don't understand, it might be beneficial to watch the next episode before you unintentionally cause harm to society.